Bismillahirrahmanirrahim. Functions of the mineral corticoid, especially the aldosterone, are discussed in this video. The mineral corticoid play a vital role and its deficiency can cause severe renal sodium chloride wasting and hyperkalemia. If there is a mineral corticoid deficiency, that will lead to increased extracellular fluid potassium concentration and decreased sodium chloride concentration. So, retaining sodium and chloride in the body is an important function of these aldosterone, and also excretion of excess potassium that maintain the blood volume and blood pressure. So, in deficiency, when this extracellular fluid potassium is increased and sodium chloride is decreased, that will lead to decreased total extracellular volume, and blood volume is also decreased. And if the blood volume is decreased, the cardiac output will subsequently decrease and the patient will be in a shock-like state, and within 2 to 3 days death ensues. So these are considered as acute life-saving hormone, uh, though not immediately fatal when absent, and they are essential for stress response, long-term metabolic regulation, and immune modulation. So treatment with intravenous salt solution or mineral corticoid replacement therapy such as aldosterone or fludrocortisone can reverse the fatal cascade. So aldosterone maintain the electrolyte balance and blood pressure, and deficiency can cause electrolyte loss and cardiovascular collapse and death, and it is treated by hormone replacement or salt therapy. So the aldosterone has got a dominant role in mineral corticoid activity. Cortisol, that is a glucocorticoid activity, has also got some mineral corticoid property, but to a lesser extent. About 90% of the mineral corticoid activity is by the aldosterone. So its effect is about 3000 times, while cortisol has got also the mineral corticoid activity, but its concentration is very high. So usually its minor contribution is there in mineral corticoid activity, but if it is unchecked, it may cause the major mineral corticoid activities. So this cortisol can activate mineral corticoid receptors that are present in the renal epithelial cells, but usually it doesn't. The cortisol binds to mineral corticoid receptors with very high affinity. They have got high affinity for these mineral corticoid receptors, and but there is an enzyme that is present in renal epithelial cell, that is 11 beta hydroxystride dehydrogenase type 2, 11 beta HSD2, that converts cortisol into inactive cortisone, and this inactive cortisone cannot bind with the mineral corticoid receptor because they have got less affinity for mineral corticoid receptor, and they also influence the intracellular redox state to further prevent cortisol's effect. If this protection or inactivation of the cortisol fails by deficiency or absence of this enzyme, there is a condition that is termed as apparent mineral corticoid excess syndrome or AIM syndrome. In genetic deficiency of 11 beta hydroxystride dehydrogenase type 2, uh, cortisol activates mineral corticoid receptor, causing sodium retention, potassium loss, and hypertension also suppresses the aldosterone level. So this apparent mineral corticoid excess syndrome, it mimics aldosterone excess, but aldosterone is low and the cortisol is the actual culprit. The licorice that is called mullety, it has got glycyrrhetinic acid in it, and this glycyrrhetinic acid, it blocks this enzyme activity. So the person who ingests this licorice, excess consumption of this may lead to symptoms like apparent mineral corticoid excess syndrome. So aldosterone is the key mineral corticoid, and cortisol can mimic it, but 11 beta hydroxysteroid dehydrogenase type 2 checks on it. If there is inhibition of this enzyme 11 beta hydroxysteroid dehydrogenase type 2, the apparent mineral corticoid excess syndrome result, and it can be genetic or licorice induced. So aldosterone, the mineral corticoid, it increases sodium reabsorption in renal tubules and also causes increased secretion of potassium. So site of action in the kidney is the principal cell or renal tubular epithelial cell or principal cells of the collecting tubule, mainly the distal tubule and collecting duct. The effect of these aldosterone is increased sodium reabsorption or conservation of the sodium in extracellular fluid and potassium excretion in the urine. So that will decrease the extracellular fluid potassium concentration and increase the sodium concentration in the extracellular fluid. So high aldosterone will lead to urine lead to the urinary sodium to a few milliequivalent. It is decreased, and potassium is dramatically or severely increased. As a result, the extracellular fluid potassium increases and sodium increases. Extracellular, as the sodium is conserved, the sodium is increased and the potassium that is now lost in the urine in increased quantities, it is decreased in the body. If there is deficiency of the aldosterone, there is loss of sodium about 10 to 20 gram per day, that is about 10 to 20% of the body sodium, and the potassium is retained, so it is decreased in urine and it is increased or retained in the extracellular fluid and can lead to hyperkalemia, the increased quantity or of the potassium ion in the blood. So this aldosterone is essential for sodium conservation and potassium balance. High aldosterone will lead to fluid retention and hypokalemia, while absence of aldosterone will lead to wasting of the sodium, loss of the sodium with hyperkalemia. So the primary action is modulated through the kidney tubular function, affecting blood pressure and electrolyte balance. So what are the effects of aldosterone on extracellular fluid volume? sodium and arterial pressure. This increased aldosterone increases extracellular fluid volume and arterial pressure, but has only a small effect on plasma sodium concentration. Why? So we will have the answer of this question. First, the aldosterone has got the effect, and it decreases the urinary sodium concentration and also increases the extracellular fluid sodium concentration that leads to water retention and increased extracellular fluid volume and blood pressure. But this minimal effect, it has a minimal effect on plasma sodium concentration. Why? Why this plasma sodium concentration stays almost constant? So mechanism is for this is that the sodium reabsorbed in the renal tubule, and there is following water that comes osmotically inside. Then the increased sodium stimulates thirst and increases water intake. And this increased sodium also stimulates antidiuretic hormone secretion and increase water absorption in the distal collecting tubule. So the net result is the sodium concentration stays stable because water retention matches the sodium retention. If there is excess aldosterone, what happens? There is decreased sodium concentration, excretion in the urine, and also there is increased sodium and water retention that increases the extracellular fluid volume and increased blood pressure. After 1 to 2 days, the increased arterial pressure, it triggers pressure natriuresis, that is increased sodium excretion through the urine, and also pressure diuresis, that is increased water excretion. So new balance is now aldosterone escape. Despite high aldosterone, sodium and water output returns to match the intake, but the blood pressure stays elevated. This concept is aldosterone escape. If aldosterone becomes zero, there is massive sodium loss in the urine, and extracellular fluid volume is also decreased and blood pressure is also decreased. That lead to circulatory collapse without mineral corticoid therapy. So here the life-saving role is of this aldosterone is emphasized. It prevents fluid and electrolyte imbalance and death. So this aldosterone escape is the restoration of sodium and water excretion despite excess aldosterone due to increased blood pressure. The problem lies that this hypertension or sustained blood pressure increase remains, and this occur after 1 to 2 days of excess aldosterone secretion. So this graph is showing the effect of aldosterone infusion on arterial pressure, extracellular fluid volume, and sodium excretion. On an x-axis, this time in days is given, while in the upper graph, on the y-axis, mean arterial pressure in millimeter of mercury is given. So before aldosterone, 100 mmHg mean arterial pressure is there, and with aldosterone it increases steadily to 115 mm of Hg. After stopping aldosterone, it returns toward baseline. So how do we interpret this? That this aldosterone rises the blood pressure due to sodium and water retention. Then in the middle graph, on the y-axis, the extracellular fluid volume in percent of the normal is given, and you can interpret that the extracellular fluid, it rises significantly with aldosterone administration, peaks around day 4 to day 6, and returns to normal after aldosterone is stopped. Then the interpretation is that the aldosterone causes the retention of the extracellular fluid, so extracellular fluid is expanded. In the lower area, this graph, here the sodium urinary excretion is mentioned in milliequivalent per day. So initial drop in sodium concentration after aldosterone is introduced in day 1 to day 0. Then there is a rebound increase in the sodium excretion. This is the concept of aldosterone escape. And the urinary sodium excretion returns to baseline after aldosterone is stopped. So what is interpretation is that the kidney initially retains sodium but then compensate via pressure natriuresis or diuresis that restore the balance of sodium. So despite continued aldosterone secretion, urinary sodium excretion increases. After several days, due to increased arterial pressure, this limits sodium retention and prevents indefinite extracellular fluid expansion. However, blood pressure remains elevated, contributing to hypertension. Now, how this aldosterone affects the potassium homeostasis. So the normal function of aldosterone is to promote renal excretion of the potassium and maintain extracellular fluid potassium concentration, and it preserves muscle and cardiac electrical stability. When there is excess aldosterone hormone, uh, for example due to some tumor, adrenal tumor, there will be increased urinary potassium loss, and the loss will result in, also with the loss there is shift of the potassium from the extracellular fluid to the cell, and this will lead to decrease in extracellular fluid potassium concentration that may go up to 2 milliequivalent per liter. So normally the concentration is about 4.5 milliequivalent. If it is below 3.5 milliequivalent, it is termed as hypokalemia, and it is due to increased secretion or excretion of the potassium in the urine and shifting of the potassium into the cell. So there will be altered electrical excitability of the nerves and muscle fiber membrane, and that prevent the transmission of normal action potential. And there is also severe muscle weakness, fatigue, etc., or called cardiac arrhythmia, and suppressed reflexes may occur. If there is aldosterone deficiency, or so it will result in increased concentration of potassium ion in the extracellular fluid that may increase about 60 to 100% above normal The concentration of about for more than 5.5 milliequivalent is termed as hyperkalemia, and it is due to the decreased excretion of the potassium and retention of potassium in the extracellular fluid. They will result in cardiac toxicity, means there are weak contraction, bradycardia, or arrhythmia, and can lead to cardiac failure. There will be nausea, paresthesia, or muscle twitching also. So this high potassium causes depolarization instability that affect the cardiac muscles, and therefore arrhythmia and conduction blocks occur. So the potassium concentration of 4.5 milliequivalent is considered normal, and it is responsible for normal nerve and muscle function. But if there is decreased or hypokalemia, that is about 2 to 3.5 milliequivalent per liter, there will be weakness and paralysis. And if there is hyperkalemia, that means it is going more than 5.5 or to 6.5, it will lead to cardiac toxicity. So increased aldosterone secretion may cause increased tubular hydrogen ion secretion and result in metabolic alkalosis. So whenever this aldosterone is increased, there is a resultant increased potassium secretion, and also the absorption of sodium is increased in the principal cells of the collecting tubule, while in the intercalated cell of the cortical collecting tubule, intercalated cells, it promotes hydrogen ion secretion in exchange of potassium that result in electrolyte shift. So there will be increased sodium retained in the extracellular fluid, and increased potassium is excreted, as well as the hydrogen ion is also excreted in increased quantity. Consequently, there will be decreased hydrogen ion concentration in the extracellular fluid, and this lead to the metabolic alkalosis, that is a rise in blood pH. So this aldosterone act like a strict housekeeper. It sweeps out potassium and hydrogen ion while making sure sodium to stay in. But in doing so, it overcleans the acid, and that is the hydrogen ion, and leaving the environment too basic, that result in metabolic alkalosis. The aldosterone stimulates sodium and potassium transport in sweat glands, salivary glands, and intestinal epithelium. So the target cells are sweat gland, salivary gland, and intestinal epithelial cell, especially the cells of the colon. Sweat gland and salivary glands, their secretion is primarily rich in sodium chloride, and the sodium and chloride are reabsorbed by the ductal epithelium, while the potassium and bicarbonate ions are secreted. So aldosterone plays its role. It increases the absorption of sodium chloride, and also it causes secretion of potassium, increase loss of the potassium. So sweat, by this mechanism, the sweat gland preserves salt in hot conditions, and salivary gland, they prevent salt loss with excessive saliva during nausea or dental procedures. The intestinal epithelial cell is also affected by the aldosterone. There is increased sodium reabsorption, and after the sodium reabsorption, the water and chloride absorption occurs passively following the sodium, And if there is deficiency of this aldosterone, that will result in less absorption of the sodium. So the chloride ions along with water are not absorbed. So it will result in diarrhea and salt loss. So imagine this aldosterone as a careful customs officer at various gates such as kidney, glands, and intestine. It checks out going salts, sodium, and makes sure that body keeps it inside. In return, it lets go of the potassium and hydrogen ion. Without it, the body loses salts in sweat, spit, and stool, leading to dehydration and salt imbalance. This picture is showing the cellular signaling mechanism for the aldosterone action and the principal cells of the renal tubule, of the collecting tubule. So aldosterone entry and receptor binding is the first step. This aldosterone, that is red triangle, it diffuses from the renal interstitial fluid into the principal cell, and it binds to the mineral corticoid receptor, making the hormone receptor complex. At this point, this hormone receptor complex formation can be blocked by the use of spironolactone, that is a potassium sparing diuretic, and it antagonizes the aldosterone action. Then this hormone receptor complex is internalized. It goes into the nucleus, and in the nucleus it binds to the DNA and initiate transcription of messenger RNA that encode proteins that are involved in sodium transport, ENaC protein, sodium transport. They also make protein that are responsible for potassium transport, and they affect the mitochondrial enzymes, activate these to generate more ATPs. So messenger RNA that is translated into protein, it increases the sodium reabsorption from the tubular lumen via epithelial sodium channel, increases potassium secretion into the lumen, and stimulates sodium potassium ATPase pump on the basolateral membrane of the cell, of the principal cell, and exchanging sodium out for potassium in. And this requires ATP that is being provided from the activation of the mitochondria. So this mitochondrial activity supports the ATP production for this process. So one target for the drug is the hormone receptor complex. There the spironolactone acts, while amiloride, another diuretic, it blocks the channels, ENaC channels, that reduce the sodium reabsorption. So think of this aldosterone as a coach that who is entering a factory. This factory is principal cell and instructing workers that are DNA machinery to build sodium channels and pumps. Spironolactone shut the factory door on the coach, while amiloride throws a wrench in the assembly line and at the sodium intake gate. In addition to these genomic role of the aldosterone that takes about 45 to 60 minutes for the action, there are some non-genomic actions of the aldosterone also. So, unlike the classical genomic effect, which require DNA transcription and protein synthesis, the non-genomic effects occur within seconds to minutes. These rapid responses do not require gene activation and likely act via membrane-bound receptors. Aldosterone binds to receptor located on the cell membrane. These receptors are not well defined as yet, and these receptors are coupled to second messenger system similar to the peptide hormone signaling. And examples of these second messenger activation are cyclic AMP, cyclic adenosine monophosphate, that is seen in vascular smooth muscle cell. So increased cyclic AMP or cyclic adenosine monophosphate, that is seen in vascular smooth muscle cell and renal collecting tubule epithelial cells, and the action of this hormone occur less than 2 minutes. There is also activation of phosphatidyl inositol system that is observed in other cell types. So current understanding and limitation of this non-genomic actions of aldosterone is that the identity of these receptor is still unknown. These are rapid aldosterone receptors. Its identity is as well as the physiological importance remains unclear, and there are many investigations undergoing. So to remember is that while endostrone's classical role involves slow genomic pathway, a rapid second messenger based action may play an additional role, especially in fine tuning of the vascular tone, function of the kidney, and electrolyte balance. Thank you for watching this video. If you have any query, please write in the comment box.